and we'll be starting our session today, our instruction course on micro innovations, macro impact. The title is Transformative Breakthroughs in Cataract and Refractive Surgery, and to just give you a brief on what the purpose of this instruction course is. Whenever we come to meetings, we see a lot of people talking about path-breaking innovations, big industry innovations, new lasers, new technologies that are coming in. But very often it is those small individual breakthroughs that really make a difference in the way we practice. And it changes the way we are approaching every patient on whatever surgeries we perform. So today we have a very interesting lineup of some really nice innovators. And we'll be starting with Dr. Neeraj Shah, then following up with Dr. Neha Dholakia, and so on and so forth. So I'd like to invite Dr. Neeraj Shah, who's the director at Shankara Eye Hospital, Jaipur, is a cornea, cataract and refractive surgeon. And he is going to talk to us on a very interesting keratoscope that he has designed to reduce astigmatism during keratoplasty. Those podium ki slides. Can we have the slides from that podium?
The second one. Good morning, everyone. Brand new day, brand new topics. So, I'll be talking about a keratoscope which we've designed for intraoperative use, which can be used live during surgery to regulate postoperative astigmatism. So if we look at the background of keratoplasty, this is the picture from 1906 when Dr. Edward Zern, he did the first keratoplasty, and if you see the picture, there is no microscope, no fancy equipment, nothing. And that is how it all began. He used just a basic trephine, a few needles, and that was it. That was how the keratoplasty journey began. And over the last 1 century, we've come a long way. A lot of fancy equipment, fancy stuff. We have immunosuppressions. Then we have fancy microscope, eye banking, trephines, all sorts of things. Yet, if you look at the keratoplasty outcomes, one facet of the outcome is graft survival. So we've reached as far as 90%, wherein we are able to take care of almost all the grafts that we implant. But if you look at the visual outcome, there are articles which report all the way up to 15 to 20 diopters of astigmatism post-operatively, post-keratoplasty. In such a situation, obviously the patient is going to have a functional outcome, anatomical outcome, but not a functional outcome. So these are many such articles discussing how to prevent astigmatism, how does it occur, what are the different suturing techniques, what all we could go for, all sorts of things. The debate has been raging on since decades. Look at this picture. This patient, a fantastic keratoplasty, fantastic looking sutures, the natural lens, crystalline lens also has been maintained, but the astigmatism is 8 diopters. Obviously the patient is going to have an extremely bad vision. So what we thought was that we need to create something which could help us manage the astigmatism intraoperatively. So in that context we thought of a ring which will be reflected on the cornea. So usually we take a graft about 7.5 mm. So we would need a 4 mm diopter ring which will be reflected off the graft surface. The concept, the product has to be new, inexpensive, simple, replicable. And for that we went back to the Bosch and Lomb keratometer formula, wherein if you just look at the formula, R is the radius of curvature of the cornea, and which is the graft. Second is the working distance of the microscope, which is usually 200 mm. The image size that we needed was 4 mm. The size of the ring that we needed is what we needed to find out. Through all the calculations using the Bosch and Lomb keratometer formula, we were able to deduce that we need a 21.3 mm diameter ring, which will be placed at the objective level of the microscope. We got this LED light flexible thing for just about $200 from Amazon, and this is how it looks. So this was placed underneath the microscope at the level of the objective. the distance of this ring to the eye, to the cornea was what we calculated. That is how we were able to deduce the diameter of this ring. This is how it looks when you look at it from the patient's point of view from underneath, and this is how the working system happens. And you can see surgery being done, sutures being placed, and if you switch off the light, this is just for demonstration how the ring looks. You can also see the ring with the illumination on, and while suturing you could manipulate the sutures in a manner such that you get a nice round circular ring at the end of your sutures and during your suturing as well. Obviously, those of us who do keratoplasty, we know that the first 8 sutures are what will determine the primary astigmatism of your graft. This is another picture, this is another video wherein a femto-DALK keratoplasty was being done, and this is the graft being placed and sutures being placed. Initially you see that the ring, the reflection, the Myers are not very round or regular. As in how the sutures are being manipulated, the Myers start getting rounder, circular, and this is how you'll know. And in case suppose you have a oblongish oval extension of a Meyer in a particular direct axis, you will probably need to tighten that suture. So coming back to the video that we just saw, this is the postoperative astigmatism 1.2 diopters, fantastic outcome. Another video, this is just the end wherein the sutures are being, this is a continuous suture being manipulated such that I'll just show you just a second. So at this point, if you see, you have a nice round circular Meyer. This is what gives you some assurance that this patient is going to have a reasonable amount of astigmatism. And this is what is the outcome, about 0.9 diopters, 1 diopter of astigmatism. So what we did was we made 2 groups, group A, group B, 50 eyes in each group. One group underwent keratoplasty with the use of this intraoperative keratoscope. The other group just underwent a regular keratoplasty. 3 parameters were checked. One is mean refractive astigmatism, mean topographic astigmatism, and the postoperative vision. So if you look at group A, which was the keratoscope group, so mean refractive astigmatism was 1.38, mean topographic astigmatism was 2.46, and to our what we had expected, the group B, the non-keratoscope group, had 4.4 diopters and 5 diopters of astigmatism on topography as well as refractive astigmatism. Then the uncorrected and the best corrected vision obviously was better in the group A, which underwent the use of keratoscope, wherein obviously since the mean astigmatism was much lower, the uncorrected and the best corrected vision was much better. So what we say is that the keratoscope is a simple, cost-effective, replicable device which can be placed for any microscope, it can be used anywhere. Most of the devices that we have currently will not be able to give you the simple devices which will not give you live, real-time ability to manipulate sutures. In the sense, you'll have to place your suture, then you'll have to check the Meyer, then you'll have to put the Meyer aside, you'll have to again control your sutures that way. This will give you real-time ability to control your sutures. This is another interesting case. This is a post-keratoplasty case. Patient came 7 years after the surgery, almost 13 diopters of astigmatism. This is how the Myers look before the intervention. You can see it's completely oval. This is the graft. The graft is in situ. All of us who've been doing keratoplasty, we know that the graft can just be separated by a Sinski. And it was just separated, not removed, and sutures were replaced. And, okay, this is looping, the video is looping again. So in the end of the video, you can see that the Myers have regularized, and I'll show you the patients. See, this is how the Myers have regularized at the end of the surgery. And the ultimate astigmatism was 3.6 diopters. Much better than the 13 diopters what the patient had earlier. This 3.6 diopters can be corrected in many other ways subsequently. So this is our team. The original concept was by Dr. J.K. Reddy, and this is the entire team who's been working on this. Thank you. Any questions?
So actually what I can think of is, because what is little bit missing there is the fact that it's subjective again to see the ring, when you're trying to make out if it's overlays or it's centralized. But if you have an interoperative guidance system, say like a Varion or a Callisto, you can actually put that Rexis marking and choose it to your right sizing of that ring and overlap it to see if you are actually becoming more circular or not.
Correct, true. So that is what, that is not available at most places, at most centers. So we were looking at something that is cost effective, and this could in fact even help students or trainees especially. And many of these post high astigmatism that we see are usually done by surgeons with a lesser experience. So, and those people are very likely to not have access to fancy equipment.
No, just thinking out loud,
true.
you can use image guidance with your, and how big is it? Is it difficult to mount on the microscope?
No, it's very easy. What we would really need is to find out the working distance and just put it in that formula. So suppose the working distance for your microscope is, let's say, whatever, 150 for example. Then we'll find out the diameter. Just it can be plugged into any microscope at the objective level and it should go. That's
Excellent.
it. Fine.
So I now welcome on stage Dr. Neha Dholakia, who's come from Mumbai, Dholakia Eye Center. And she has a very interesting innovation which I've used personally, and I find it to be a really path-breaking innovation. So welcome, Dr. Neha. Can we have the slides?
Thank you. So, beginning se karenge, please. Can you all see it? Yeah, start kar sakte hain. So basically broken IOL complications have been the most dreaded complications for years. You do a perfectly good cataract surgery and you see the haptic optic junction break, or you see the lens just shoot through and puncture the PC. And I think we all have experienced this at some point in time, and we're really disappointed. We have to remove the IOL. Sometimes we insert the IOL, and these are good lenses. These are not second-grade lenses. These are the best companies in the world. So this is an Envista. The previous one was an IQ. And then we have to remove the IOLs. The current methods are either extend the full incision or the twist and out technique. Thoda volume badayenge.
Volume.
And this twist and out technique, if you have a rent, you can't do. You have to be a very expert surgeon to be able to do it. The third is using the scissors. And here, because of the opening and closing of the jaws of the scissors, you can touch the endothelium. And if it's open behind, it can even puncture the PC. This can leave behind striate keratitis and sometimes even Descemet's detachment. Corneal edema is generally very common. So here is, thoda music badayenge please. So here is innovation where you see the lens is being held by a special forceps, and the tip, which is just like a phaco tip, it's a solid tip, not hollow, but it has a sharp V-shaped front, and you just slice through the lens as if cutting through butter. You can slice the lens into 1, 2, into 3 parts, but if it's a little bigger, thicker lens, maybe even 4, 5 slivers. And then you just realign the pieces and remove them. So first you have to prime the phaco probe, just as you normally do. Once the phaco probe is primed, this is what the tip looks like. It's made of titanium. The forceps are made of steel. And all you do is just press on the foot pedal, and you can slice the IOL into 3, 4, 5 slivers. Always I would suggest that to try it first under vitro, in vitro under saline. The temperatures were checked at the tip, normal phaco tip versus the IOL cutting tip, both were more or less the same. The vacuum has to be 0, aspiration 0, irrigation should be on, and longitudinal power, not torsional, not linear, just fixed longitudinal. I have cut even IOLs at 20% power, so between 20 and 30. It's very important to give good counter pressure. In industrial use, this is how it would be to cut a piece of plastic with a blade versus an ultrasonic cutting blade. So in the first case it was impossible, but here it is possible. There are separate tips based on the length, the thickness and the threads for different machines, but we have tips for all the machines. Avoid interchanging a tip from one machine to another. It will work, but it will not give you the optimal power. So this is a case of a 60-year-old male patient. He used to drive at night. He was one-eyed. He had come from Dubai. And during the primary surgery, the injector got jammed. And because of that, there was pitting on the IOL. He wanted to be specs-free. And though his vision was 6/6, he had severe dysphotopsia. Explanting, you can see the pitting there. And this was operated by Dr. Santosh Bulchandani from Bombay. And he called me, he's saying, Neha, can you send me the cutter immediately? Luckily, I happened to have one for his machine. So under visco, he's sliced it. And this patient, after the primary surgery, didn't have astigmatism at all. So through the same 2.2 millimeter superior incision, without extending it, without stretching it, without twisting, he could remove the IOL very easily. He implanted another IOL in the bag. And this was the result on day 1 post-op, plano 6/6. He had a crystal clear cornea. You can see the air bubble. It's just the first day post-op. Patient was very happy. He could fly back in 3-4 days. The second case done by Dr. Kamal Kapoor, opacified IOL, 32 diopter, hardened, high hypermetro, very shallow AC. So here he's not tried to manipulate it too much because the AC depth is not great. So here he's first cut the haptic optic junction and then he's just cut it into 2. You can rotate the IOL and do stuff, but here since the space was very less, he didn't want too much manipulation. So he's just cut it into 2, but one can always cut it into 3 slivers also. And now he had to extend it just a little bit. So broken IOLs at the time of implantation is one indication, which is something we're always very fearful of at the end. Opacified IOLs to be removed. And these are little harder, so with the scissors they are difficult to cut, but with this they are really easy to cut. Dislocated subluxated IOLs, IOL exchange for halos and glare dysphotopsias. In the future we will get a lot of refractive surprises with patients who've been operated for LASIK prior, and if they have very high expectations, having this tool, God forbid something goes wrong, we can just like a vitrectomy cutter have this as a standby. And I think every second day I get a call from somewhere in India that we used your tip and it was truly very helpful, and thank you very much. It's, the website is iolcutter.in. Once again, if you just notice, I have to give good counter pressure with the left hand. The sleeve is intact. One can ETO it and keep it aside. Now, when I did this, Dr. Pankaj Lande, he sent me a video. He's saying, ma'am, I've used it for another thing. He's giving good counter pressure, and this is a very hard black rock solid cataract. And here you see he's using the counter pressure with a hook and using the lower jaw, the lower V of the IOL cutter. And honestly, he's done it like almost like a femto, and he's very skillful a surgeon, And now he goes ahead and clears it up. So this is an off-label use. This tip has been patented now, Australia, UK, US, India. And this is just one more off-label use which I thought I should share. Thank you very much.
Thank you, Dr. Neha. So the two things that I wanted to bring about when I used it
Yes.
is one, the machine realizes there is something else, so it
Yes.
shows an error every now
Yes,
and then.
yes.
So you have to be ready to get out of that error to continue it.
Yes, yes.
And the second is rotating the IOL, because sometimes grasping the IOL after making the first sliver is very difficult.
Yes, because the center is very thick. So one can again bring the thinner part towards the side of the forceps and then grasp it again. So that little maneuvering, I think one case, if you do, then you are very confident about the second case.
Yes. Also, one last point was using a good viscoelastic, maybe
Yes.
like a soft shell again.
Yes.
Using a dispersive and then a cohesive, so
Absolutely.
there's heat dissipation.
Yes.
Because I'm sure some heat dissipation is there, but otherwise it cuts the IOL just like butter.
Yeah. It's good, and I feel very happy because I think there are far better surgeons than me, and what I could do in my cases, they've done such a brilliant job, including Samresh, and it's very heartening to just get these videos from everywhere. So thank you very much.
Thank you, Dr.
Bye. Bye.
Yeah. So, my name is Dr. Samresh, and I am a cataract refractive specialist working in Jaipur at Raghudeep Eye Hospital. And I wanted to discuss something interesting that we saw and we discovered in our hospital a few years ago as to what happens when we actually do a cataract surgery. Because we as surgeons are so involved in the nitty-gritty of putting an IOL and getting a good visual outcome. But there are certain things that are hidden behind, and we don't know where we're placing the IOL in normal eyes or in eyes where, things are not right. So generally the tendency is to put an IOL in the capsular bag, and that's what all of us want to do. And that's generally a good idea. But sometimes you have patients where the bag is compromised or not there, or patients with aphakia, or if you cause an iatrogenic complication. And sometimes when we place these lenses, we really don't know what's happening behind the iris, and we don't know what tissues we are manipulating. So we decided to create our own version of a Miyake Apple View in our clinic. We found a very nice old microscope, operating microscope, and we decided to break it apart and mount it upside down on a table. So as you can see, there's a Zeiss microscope that's mounted upside down, which has a camera, including both a regular and a high-speed camera. So the idea is to use a cadaveric eye, sectioned cadaveric eye, stick it half onto a slide, operate from the top as you would do a cataract surgery or any other ocular IOL fixation, and to record the surgery from the bottom as to see what's happening inside the eye when it's being done and what is the outcome like. So one classical example we'll start with is a patient with subluxation or a zonular dialysis, where we would try to do a capsular bag fixation rather than eating it all out. So most often we are challenged with cases like these, where we have to understand that whether it is important to preserve the capsular bag or one should remove the capsular bag and go ahead and put a newer technique of fixation like a glued IOL or a Yamane fixation. What we need to understand is when we put an IOL inside the eye, the foreign material, hydrophilic, hydrophobic, PMMA, whatever, is shielded from the rest of the ocular tissues by the natural capsular bag, which is an alive tissue. And as you can see over here, this is a patient who's had a Cioni fixation. You can see the element over here. But you can see that a hydrophobic lens is well placed. You can see the CTR there. And it's completely shielded from the rest of the ocular tissues, the anterior vitreous face, and the iris uveal tissue with the capsular bag, which is as close to normal human physiological anatomy as we can be. But sometimes the lenses are so dislocated that there is no other option but to go ahead and do a complete vitrectomy for these patients with the lensectomy. So like I said, this is a well fixated capsular bag using a Cioni, and as you can see, the haptics are there, and the capsular bag and even the CTR ring is being shielded very comfortably. And there's only one point of fixation. We need to understand that the anterior vitreous face and the posterior capsule is not only there as an anatomical barrier, but it also provides functional stability to the eye and prevents the movement of free radicals, the diabetic changes from the anterior to posterior compartment and vice versa. But we are not able to retain it at all time points. Like here, it's a spherophakia with dislocate, so we need to take out the entire capsular bag lens complex. and we are left with an eye that has no structure in it, and now the compartmentalization is gone. So the anterior and posterior chamber is one, as you can see over here. In this case, age-old technique is to use a scleral fixated IOL. And so in this patient, when we go ahead and fixate a scleral fixation, this is a 2-point fixation using a Gore-Tex suture. Gore-Tex again is an off-label use for ophthalmology, but it's being used very commonly now. Our standard dictum is to go 1.5 millimeters from the limbus and do a fixation of an IOL there. And this is a PMMA IOL typically. Now this is how the IOL would look if you were to see it from inside the eye. That's the fixation points. But notice how the haptics go beyond the fixation and rub through the ciliary processes all the way. This is a larger IOL, and it's very anteriorly placed. As you can see, it's almost touching the iris tissue. Now, if you were to leave a lens like this inside the eye, there'll be constant rubbing between the iris tissue, ciliary processes, and these PMMA lenses that could potentially lead to what is known as a long-standing uveitis, glaucoma, hyphema sort of a picture. Another more popular technique now, because it's easier to do and it's also the learning curve is lesser, is intrascleral fixation by one of many ways. So this is just to show you a classical intrascleral fixation using a glued IOL technique. Now we are using posterior chamber lenses to do glued IOL. So we have to understand that these lenses are meant for bag fixation or sulcus fixation, but not meant for intrascleral fixation. The haptics and the design of which are not conducive for that fixation. So when we are manipulating, when we are trying to externalize these haptics, sometimes we break or we kink these haptics, as you can see over here. Something that we would not really see because we are so focused on fitting the IOL inside the eye that we sometimes tend to overlook and miss out these subtle findings. Notice how the haptics again, which are over here, again as you can see, are going through the ciliary processes and out, and this will definitely lead to some sort of a uveitic picture in the eye if the eye is prone to it. So we decided to see what, where we are fixating. So this is us at 1.5 millimeters from the limbus, and you notice you're going straight through the ciliary processes. The standard dictum of where you should place the lenses goes straight through the ciliary processes, and it's the pro-inflammatory area of the eye. What if we could try going a little posterior? Maybe a 2 mm posterior fixation. As you can see over here in the cadaveric eyes, this is 1.5 from the limbus, 1.5 mm from the limbus, and you're straight through the uveal tissue. And at 2 millimeters, generally you tend to avoid the uveal tissue and you get into the lesser inflammatory part of the eye, where the eye is supposed to be more quiet. But that also means the IOL is going to fix so much more posterior from the iris. And again, very difficult with these bag fixation scleral lenses, 3-piece lenses, because they're meant for anterior fixation, so the haptics are not that long. Just to show you a Gore-Tex suture going straight through the ciliary processes, while a posterior fixation of a scleral fixation using Gore-Tex going out of the ciliary processes. Now these PMMA lenses can actually be fixated a little posterior because the haptics are big and the IOL itself is a little bigger, so it can go back. So this is the sweet spot for fixation of an IOL, at the junction of the pars plana and the pars plicator. But it's anyone's guess as to where it is, because all eyes have different anatomies. Myopic eyes will behave different from hyperopic eyes. So we decided to understand if there's any way we can find out where there is a way to technique to find out which is the area of the pars plana, pars plicator junction, and that point would be a good point to fix the IOL. So here we can see that we are using an infrared light, infrared LED, much like an LED that you would get in a remote controller of your televisions, and do a transpalpebral transillumination. So you're putting the infrared light underneath the lower lid and lighting up the eye. And on the other hand, here I'm using a security camera, CCTV camera with a +10 lens. And I've removed the infrared filter, so the lens can pick up infrared light. And the moment you do that, you see this area of the junction of pars plana, pars plicator, which is where you want to fix the lens. So you can move from a blind procedure to an image-guided procedure, where you can now put this LED and the torch and then mark points where you want to fixate the IOL, or even not IOL, maybe give an intravitreal injection. You don't have to do a blind procedure, and you can do a targeted procedure through the safe zone of the eye. It's not new. Infrared transpalpebral transillumination has been used on and off and has been published for seeing intraocular tumors, and sometimes for some glaucoma procedures, but it's never really been used for any fixation techniques or any image-guided surgery. So with this in mind, with this technique in mind, we must understand that if we can somehow work this through in our clinics and try to fix the lens just a little more posterior, maybe we'll have happier patients with lesser complications in long term, and maybe these surgeries can also become image-guided. Thank you. With this, I'd like to invite on stage Dr. Sri Ganesh, who's the founder and director at Netradhama, group of eye hospitals in Bangalore. And I'm sure most of us know of him and his innumerable innovations. But for those of you who don't, he has a history in decades of innovation, and I'm sure we'll get to hear some really good ones today. Thank you, sir.
Thank you, Samaresh, for inviting me to this very interesting session. I'll be speaking on how to innovate, how to go about innovating, and my ideas and thoughts and some of my innovations and how I got the ideas. So how do you actually innovate? So usually there is a roadmap on going about innovations. First is you have a problem, so you identify the problem. That is basically your research question. And you want to solve the problem, so you get an idea. And you may get an idea anytime. Sometimes you kind of relate to things in daily life and you get the idea. So then you need to define the need for this innovation and understand the opportunity which is available. Then you go about inventing. Okay, there may be a design, development and testing phase where you actually kind of look at whether the idea is worth pursuing. And then there's a stage of implementation, which is basically the proof of concept and risk analysis stage. And then you go on to the prototype testing and the clinical trials, which prove that this idea works. And that's when you register your intellectual property by applying for patents, and then you can get funding, and then finally you can commercialize the product, and that is the innovation. So there is a difference from an idea to an innovation, because an idea is just in your mind, but innovation is the final product which you can commercialize. So let's look at some of my innovations, and this was actually an interesting I was thinking about capsulotomy, fixated lenses to avoid dysphotopsia and rotation, and I was driving my bike. I stopped my bike, put on the side stand, and then I had a eureka moment. Why not have a swivel haptic IOL where you have two swivels which can swivel over the anterior capsule and the capsulotomy. So I made an IOL with biotech, and then we have worldwide patents for this, and this is the latest iteration of it, which is a toric IOL. We had a lot of challenges on the way. We had PMMA haptic initially, and it was breaking when we loaded the lens. Then we got a new kind of a material for the swivel haptic, and this is the toric version. So you just swivel the haptics over the capsulotomy. It captures the capsulotomy, and then the lens is very stable. It's more anterior, the ELP, and you get a perfect alignment. There's no rotation. There's no dysphotopsia. This is one of the cases. So we have also had a publication, our initial clinical trials, and now we have worldwide patents, and we just got the approval for multicentric trials. And once we do the multicentric trials and then commercialize it, then we hope that it will be available in a couple of years. So it's, once you start with an idea like this, it takes maybe like a decade before it can mature. Then you can have simpler ideas. See, when you are implanting a toric IOL in a small pupil, it's very difficult to know the axis. So you may have to retract the iris, look at the axis, and then you're still not sure at end of the surgery whether it's placed on axis. And retracting the iris causes release of iris pigments, prostaglandin release, can lead to post-op uveitis, IOP spikes, cystoid macular edema. These are all issues. So I was thinking how we can kind of solve this problem, and then I was looking at toric IOLs and breaking my head because most of the Indian pupils are small. Then I was at the gym working out, and then I just put down that weight on the bench, and then when I lifted the weight, I saw the indentation mark there, which kind of disappeared after some time, and then I had my eureka moment, and then I knew I had kind of solved this problem. So I made a toric marker, the Ganesh toric marker, which has two windows to see where you're marking, and then you can make a temporary mark on the center of the lens, and then implant it, and then it's very easy to align it even if you don't see the peripheral marks. So this is the Ganesh toric marker from Epsilon, and then you can just, you see you have this indentation there. This is on a J&J lens. You place it, and then you can see it very clearly. Even if the ink disappears, you can see the mark, you can see the indentation because of the reflection of light. So you can't see the peripheral marks at all, but you know the central mark is there, and then after some time it disappears. And first day, post-op day, we have also looked at scatter, we have looked at the OSI, and the lens is perfectly normal. So it's a temporary mark for placement which lasts, it remains for about 2 to 5 minutes, and then it disappears. Enough time to kind of align your lens. So it's a very simple idea, and it works. And this is something that the idea from, your day-to-day activities, and then you suddenly get an idea. So you have to relate. Necessity is the mother of invention. So when you have a problem, then you're thinking about it all the time, then you kind of get an idea. So this was a cystotome maker, the Ganesh Grewal cystotome maker. So our assistants keep bending and making the cystotome, but sometimes you have multiple assistants in different ORs, and each one is bending the cystotome in a different way. So there is no standardization, and then it's frustrating because your rexis, you may not get a good rexis because the cystotome is not okay. And the Alcon cystotomes are very expensive. So I thought, okay, we'll make a cystotome, we can have a cystotome maker, which is very easy for the assistants, and which gives you a very standard cystotome. So this is the cystotome maker, and this is, we made it like pliers, and this is how it acts. So you have a small indentation for the hub there where you can place it, and then you have a block which actually bends the tip of the needle, and then so this is how it works. This is a 26 gauge needle, you just place it there, this is a BD needle, and then you just crimp, you press the pliers, and then you can see that the tip of the needle is bent exactly. So you don't have to use a needle holder, it doesn't damage your needle holders, and then you kind of just get the perfect angulation. So that is how you make the cystotome, and we got these dimensions from the Alcon cystotome. And so you get an exact reproducible cystotome every time, irrespective of the assistant, and then you can make a very nice capsulorhexis. So you have the exact bend, you don't have too long a bend in the needle, so this kind of solved that problem. And surgery is all about standardization. So if you have standard techniques, if you have standard instruments, then you get standard results. So this is how the cystotome maker works to give you perfect cystotomes for your surgery. And this is available from Epsilon. So that's one of the ideas there. Then sometimes a colleague comes to you with a problem. So we have a training program. Many of the fellows have PCRs during phaco, and then you have fragments left in the chamber, and if they go after these fragments, then you have a nucleus drop. So the safety net device is a temporary rescue device, and this is something that we made with biotech. So it is, you have version 1, version 2. It's like a grate, which is circular. Overall diameter is 7.5 millimeter. It's made of a foldable hydrophilic acrylic material, which you can just place under the fragments and then safely remove the fragments. And oops, sorry, let me play the video. So then I kind of designed this, and then biotech made it for us, and we'll show you this device in action. So you can see that there's a PCR and a very large piece. So if you go after that, then you're going to be in trouble. So you just put in visco. If required, you can do a limited anterior vitrectomy, and then you make the side ports there. Put in this device, inject it in front of the iris. It opens up like a grate, And then you can use the iris, you have your iris hooks, so you can kind of hook it up with the iris hook so that it is stable. It does not change the plane, nor does it dislocate into the vitreous. And then you have a very stable platform where you can safely go in and do phaco and remove this fragment. So you don't have to convert into an SICS, because most of the fellows convert to an SICS when they have this. So you can still maintain the small incision. Then you can remove this. This is a temporary device. You just have to pull it out with forceps. Comes out very easily. Then you can do your bimanual IA and your vitrectomy. You can see that's a very large PCR, but that's antravitrectomy being done. And then you can place the lens, three-piece lens in the sulcus and do an optic capture. So you can kind of save the day with this. There are many other innovations. Also described a technique called lenticuloschisis, which is a no dissection technique for lenticule extraction in SMILE. It's published in the JRS. Also, we described using SMILE lenticules to treat hyperopia, called it FILI, femtosecond intrastromal lenticule implantation. We published a 5-year follow-up, and manual cyclotorsion for SMILE, viscochop for femtocataract, and also some SMILE instruments. So coming to research, research is a frame of mind. So if you're always thinking about the problem, you get an idea, then you can pursue it and then innovate. So you don't need big laboratories, you don't need expensive equipment. So it's all in the mind, and this is what I would like to convey. This is just telling you about APA-CRS, the 37th APA-CRS in Ahmedabad in August. So please register and come for this meeting. Thank you very much for your attention.
Thanks a lot, sir. I think you have a couple of questions coming up here. Mic on.
Yeah, superb innovations, just brilliant. But one thing I have noticed, I've also made small innovations, not so good, but whenever we are more relaxed, one has to have like the frame of mind that you have, then the innovations come. If you see, Newton was sitting under an apple tree. If you see, Archimedes was in a bathtub. If we see, Pythagoras was just staring at a floor. And even the...
And I was riding my motorcycle.
Motorcycle. So that's being in a very relaxed state of mind and not actually overthinking all the time. And even Buddha got enlightenment under a tree. And all the examples, even the theory of relativity of Einstein, he was resting. Many come when you're taking a nap at night. And I would also suggest whenever you get an idea, just open your iPhone and jot it down, because somehow by morning it's just evaporated. So that's all.
Yeah, you can jot it down sometimes on napkins when you're having dinner.
Exactly, exactly.
All sorts of things happen on your phone,
yeah.
Whatever piece of paper you get.
Absolutely. Because many times if that moment's gone,
Yes.
then to get it back again, you'll scratch your head and you'll not be able to think what it was again. That's all.
So it's a frame of mind. So you have to be calm.
You have to be very
Because
calm and a relaxed person in general to be able to think. So, but this is a very good trait, because I guess, you are doing a lot of work also at the same time to be like that. They're very paradoxical situations. Yeah. Thank you.
Thank you.
Sir, every time I look at all these, I really get so inspired. So thank you for keeping stimulating us. I just have always thought of one thing. So with that, the swivel haptic.
Yes.
Is there a difference in the PCO because you are clipping the
We did, see, the thing is we also were concerned because we thought there's going to be a space because it's more anterior, but what happens is the PC actually comes up. In about 3 weeks, you have the shrink wrap effect. So even if you leave a patient aphakic, there's fusion of the anterior and posterior capsule. You see that the posterior capsule actually comes up. It's not convex. So we did UBM in these patients, and we see that the PC comes up, and it's got a 360-degree square edge. So a PCO is not higher in these lenses than the regular lenses. We were also worried about, okay, if the swivel haptics, they rub against the undersurface of the iris, will there be pigment release? So we also did gonioscopy to look at the pigments pre-op and then post-op, but there was no increase in the pigmentation, and there's no higher incidence of uveitis or anything like that. And now it's been like, since the first lenses we implanted, almost 8 years, and these patients are still doing well.
Thank you, sir.
Also, sir, one last question on the Rexis, the cystodome bending. So it's a brilliant idea, especially for fellows, because they sometimes can't make the right ones and they overbend. Yeah. The needle tips are standardized, or not all companies will make the same needles?
This is with the BD company, and it's pretty standardized. So if you're using any other company, most of us I think use BD needles for cystodome. These are the insulin needles. If you're using different companies with different lengths, then you have to use the half-inch one only. So if you're using a different company, different length of needle, then it may not work.
Thanks a lot, sir. Thank you so much.
Thank you.
So with this, we are going to invite on stage for a very interesting keynote address, Dr. Audrey Rostov, who comes all the way from the beautiful city of Seattle, and she's going to be talking to us on managing complications in SMILE and LASIK. Welcome to India, ma'am.
Thank you so much. It's always a pleasure to be here. And thanks to everybody in the room. We've got the few and the motivated here. I'm going to be discussing management of SMILE and LASIK complications. No relevant financial disclosure. When it comes down to a very basic level, what do patients want? They want two things, no matter what type of surgery you're doing. We all want great outcomes, and we all want to have the safest procedures. There was a really nice article in JCRS, the Orange Journal, that once again showed that there's essentially equal outcomes for LASIK, SMILE, and PRK. So whichever method of laser vision correction you choose, you can be reassured that your patient will have an equal outcome. When I think about SMILE, LASIK, and PRK, I think about it like this. I do, when anybody is a candidate for any of the procedures, I tend to do SMILE, since you preserve more corneal integrity without the flap and there's less dry eye. LASIK, however, is my favored for cases of higher astigmatism, very low myopia, or if there's a corneal scar that wouldn't allow for a good SMILE procedure. And I really reserve PRK for some enhancements, or those with anterior basement membrane dystrophy. We all know the story and the studies by Dan Reinstein showing that SMILE versus LASIK, there's less dry eye, there's less of an overall decrease in corneal sensation, and there's a faster recovery. We're also familiar, of course, with the steps of lamellar dissection here, and therefore we can talk about complications. I'm not going to discuss infections, as that could be an entire symposium on itself, but will go ahead and discuss all of these different complications here. With suction loss, if there's a suction loss later in the procedure, during the cap or incision, you can simply redock and continue. The reasons for suction loss would be a wet corneal surface. I'm always sure to dry with a little Muracell sponge right before I do the docking in the fornices, just slight dabbing, and this helps to decrease the incidence of suction loss. Of course, if you have eye movement, a nervous patient, this can also be an issue. I also talk to them all during the procedure. I'm reassuring. I tell them to look at the light. I tell them not to be concerned when the light disappears. And verbal anesthesia and constant reassurance can also help. Of course, now with the new Visumax 800, which you have had here in India for longer than I've had it in the US, there's shorter treatment times now, less than 10 seconds, and therefore with the under 10 seconds, it makes suction loss really pretty much a thing of the past. I don't always dress in a hyena outfit to do my surgeries. This was at the AIOS CRS meeting. For those of you who have not been there, you are required to wear a costume during your presentations, and they provide them nicely for you. difficult lenticle extraction. So if you make it through not having a suction loss, what can happen. And I was actually just teaching SMILE yesterday here in Delhi, and to some of the newer surgeons, fellows and just out of fellowship. And if you have a difficult lenticle extraction, each step prepares you for the one next. And if you have meibomium secretions, or you have anything that's on the patient interface device, or you have something, epithelial disruption, then this will be translated into the SMILE procedure itself and can lead to difficulty with lenticle extraction. So if there are debris in the tear layer, you'll get these skip areas, and the thing is to not do anything if you have those meibomium secretions in the first place. You want to wipe them off, rinse them off, and redock again. If there's scars in the area of the SMILE treatment zone, offer LASIK or PRK, because any kind of opacity, as we know, with the femtosecond lasers will cause the pulses not to go through. And so if there is a small scar that is significant enough in the SMILE treatment zone, then I opt for another procedure. If it's outside of the SMILE treatment zone, you can then, of course, continue. You need to identify, of course, the anterior and posterior planes, and especially in first getting started, of course, I'm talking to a room full of experienced SMILE surgeons here. However, when I train the fellows and or new practitioners to SMILE and let them know that it's really, really common to think you've dissected anteriorly, but you've dissected posteriorly, and to do this anterior rescue maneuver, get really, really anterior with that tip, and then you will find your plane. A lot of times people say, oh, I think I dissected anteriorly, however, I can't find the posterior plane, and I would say that 9 times out of 10, you in fact have dissected posteriorly first. For thicker corneas, I actually bump up the energy by 1 step, and so when looking at the energy settings under expert mode, what I do is if it's above 580, I bump it up 1 step, which is equal to 5 millijoules, and you have to do that all across. You need to, of course, balance your energy with your OBL. If you have a retained lenticle, the nice thing to do is to go back and get that, start from the middle dissecting, and then you can go ahead and lift the end, and usually comes right out. If it's small, and this was a case where I had done a SMILE procedure right before COVID, right before the world shut down. I didn't see the patient until almost 1 year later, and they had this very small little area at the blue arrow with a retained lenticle. I could not get into the SMILE interface at that point. I did a PRK, and that tended to work well. DLK with SMILE versus LASIK tends to be patchy rather than diffuse. I recommend rinsing earlier. If you do a PRK after SMILE or LASIK, I actually prophylactically give them a 5-day course of oral steroids. I give 40 milligrams of prednisone. You can either do it for 5 days or 40 for 3 days and then 20 for 2 days. Interface fluid syndrome, similar to PISC, it can mimic or coexist with DLK, and so sometimes what will happen is you'll have a DLK and then you start the steroids and you wonder why they're not getting better, or there was initially they were getting better and then they didn't, and in fact you can have a case of interface fluid syndrome. Of course, just like with PISC, we treat with IOP lowering meds, and keep in mind you want to minimize steroids. In the case of epi-ingrowth or implantation, this is another thing that can occur. If it's with SMILE, most likely it's actually epi-implantation. You introduced the epithelial cells during the procedure versus LASIK, where it's most likely ingrowth, meaning that there was in fact a channel for the epithelial cells to go in. You want to go ahead, and you'll see this in SMILE, you'll actually see it early. And go ahead in, this was a case I had. I obviously had introduced some epithelial cells inadvertently. And I went in with a little Sinski, and you can see the before and after. This is a case of LASIK. If you have regressed epi ingrowth, sometimes you'll see this years later. If there's a demarcation line, no worries. If, however, it has appeared, then one thing that I like to do is, in fact, a YAG treatment for it. This is a case of flap dislocation from trauma. We've all seen these, and there was irregular astigmatism. You want to make sure you replace the flap as best you can, and then after replacing the flap, you can treat the ingrowth with a YAG as needed, and then if needed, you can do some PRK to correct the refractive error. And of course, no complication talk would be complete without mentioning avellino-corneal dystrophy after LASIK. I don't really see a lot of it in my area. There is testing for it if you have a lot of that in your area, and that's something that can be considered. So I want to thank you so much for your kind attention, and thanks for inviting me here. It's a pleasure always to be back in India.
I just wanted to ask one question, ma'am. Sometimes, despite being paranoid about not having microstriae when ironing it out, I sometimes, very rarely, particularly in patients where I'm ablating a lot, I will tend to see them, very fine ones. And it tends to bother only a few patients, not all patients. So how aggressive should I be if I see those microstriae in the central cornea to take them back into the OR to maybe flatten them, or should I just tend to leave them?
I'd say most cases, they truly are microstria and they're not going to be significant with LASIK. On the table itself, with LASIK or with SMILE, right after, I do actually, with a wet Muracell sponge, make sure I try and, smooth, do what you can. Of course, especially you'll see this in the higher myopes. But I'd say it's rare that a patient, I think it usually bothers the surgeon more than the patient. If it's more than that, though, then sometimes you do have to take them back. But unless it's bothering the patient, I really would count it as 20 over happy.
Thanks a lot, ma'am.
Great. Thank you so much.
So for our last talk of the session, I'd like to invite with great pleasure one of my very close friends and teachers, Professor Dr. Rohit Shetty, who apart from being the chairman at the Narayan Netralaya group of eye hospitals, has so many accolades that it will take half an IC to finish it. But in short, he's a clinical scientist and he is a PhD, and he's made so many doctors do PhDs in their areas of interest. So we would love to hear your innovations in refractive surgeries.
Thank you, Samresh. My talk today is on innovation in refractive surgery. These are my financial interests. So if you're looking at today the 10 commandments of a very good LASIK practice, it starts with a very robust diagnosis and it ends with great skill transfer. And what is interesting here as we move on is a good symbiosis between a machine and the diagnosis. So when you're looking at the newer diagnosis, we have options of biomechanics, the epithelium, the stromal imaging, and also the future diagnostics is going to be driven by the genetics in the cornea. The most interesting new device which has come is the MS39, which is a hybrid topographer OCT. One of the advantages of it helps to understand the way epithelium is mapped, the way the stroma is, stromal elevation is, which is minus your epithelium. This is just a comparison of the current generation topographers, OCT machines. What's interesting here is the new generation, which is coming up even as we speak today, is the pentagram OCT, where your axial resolution is getting better and better. So there's a day will come when we'll probably be seeing a sub 1 micron resolution, which will look at the cellular structures without need for any contact in intervention. We look at epithelial maps. This is how you compare. The Solix has the best epithelial maps in terms of giving a 10 millimeters. The Pentacam OCT also, but MS39 is great in OCT, but still limited with 8 millimeters in its entire corneal plane. So the next generation of refractive is trying to see the unseen. For example, you are able to map the Baumann's, and you're also looking at different levels of epithelium. For example, this is your Barman's, and this is your basal epithelial cells, and this is your superficial cells. So you, at this dimension of imaging, you're able to look at directly, even making 3 levels of classification of your epithelial cells. And what is interesting is when you look at the epithelial cells in this level, and also look at other imaging, it completely changes the dimension of refractive surgery. Then comes more innovations in trying to see what is hidden using the polarization OCTs. The corneal biomechanics, we have now the role of Corvus. There is also, there was little interest in the Brillion. We do have a Brillion microscopy, but very, very moody and erratic technology at this point of time. But eventually, I think it will reach a stage where it can be a point of care to the practice. This is imaging of your collagen. The collagen does not show a birefringence properties. So that means whatever light goes in, the polarized lights, when you does not have a birefringence, it picks up as a dark blue, and your peripheral fibers are anchoring fibers. And that picks up as red because that's where you start showing those anchoring fibers are oriented differently. But in this case, if you look at this, there is a loss of birefringence, the loss of orientation of your collagen, so that you can change in the shape, and this is matching to what your biomechanics is. The future is going to be not looking at the topography, which is just an imaging of your surface. It's about the cellular structure. When it comes to innovation in refractive surgeries, this is a roadmap I've used from Halcon platform, where they started with, most of the companies have similar kind of platforms. Started with wavefront guided, and most of them are now trying to look into more customization. Many machines are moving towards ray tracings, and one of the areas of ray tracing in non-lenticular is InnoWise, where Wavelight Plus, they use different names, but now this is what it is. It looks at a complete wavefront analysis from a ray tracing point of view, and then makes your own model of eye where you can plan your refractive procedures. There are various advantages. Many machines now look at epithelial remodeling as one of the factors. But again, these are all things which is evolving. We need to study, we need to know. Epithelial remodeling is not as simple as optics. Biology is involved in it. So when you claim that it is doing it, we have to understand the biology may have a different answers to it. And this is platforms. I'm sure there are a lot of things will be discussed over time. So one of the new things which I've been using the last few months is again one more ray tracing from a completely different platform called AIOS, where it looks at different levels of measurement, and what it does is it uses different light conditions to measure the pupil size, and then your ablation zone is based on the pupil size based on 8 different light conditions. And this is how a complex cornea's ray tracing is done. The ray tracing has to happen from your epithelial level. So your epithelium and how the ray tracing refractive index changes, refractive gradient changes, your anterior, posterior, and total, and then how it reaches your retinal surface. So ray tracing is something very new and exciting, but we have to understand that it has to be done in a proper way. It's like AI, and if it's not done, and if it's just a simple extrapolation of data, then it will probably not work. And this is exactly how an epithelial map has a ray tracing epithelial map compared to, that means it's the component of it, how much of it is involved in this process. And it uses a completely different form of ablation zone based on your pupil size, and also it's also heavily dependent on your ray tracing of your epithelium. And you can have a different zones, different customized zones, and creates an ideal shape. And each one of your corneas, and this is fantastic for when you're looking at a very abrated and irregular type of corneas. Then we have the excimal platform from Schwend, which looks at again a different aberration-free corneal wavefront there's a heavy insight into the presbyopia lasers, and this talk I'll be giving it later. There's already been talks about the small incision lenticule procedures, so I'll just skip. I think a lot of this is going to be dependent heavily on the future is about the lasers, energy, spot size, the optics of it, and every company is trying to integrate beautiful diagnostic machines. I think that is what going to be the next innovation, how you integrate your diagnostics to the laser, lenticule laser procedures. People are working on shapes. Shapes will have a huge impact in the way your aberrations will be neutralized, or you create a presbyopic lenticule platforms over time. And this is a work we did with different lenticule shape and geometry out there. It is also important to understand in today's context the power of immune profiling, because immune profiling it's like whatever kind of surgery you do, your biology, if it's not well, then your healing becomes a challenge. So one of the major reasons why patients come to you unhappy is not your refractive surgery or cataract surgeries anymore. It's because there is an altered immune mechanism, whether it's your dry eye, whether it's in your anterior chamber. So the role of point of care kits, which we've been speaking about, will probably have a huge role in predicting different types of outcomes, like for example haze, the edema healing, and every aspect of your healing can be predicted. And we are getting into a new dimension. Me and Professor Ganesh, we always been discussing about the role of Smile Extra and of strengthening the corneas. And many times we have a challenge. We use our decision heavily is based on your topographies, and sometimes we may be right and we may not be right to do the procedures. But ultimately, it has to be dependent on how good is your collagen. So one of the areas of work we have been doing, I mean, this is a little complicated, like how you do an FNSE. Like, I should just take a minute more. So what we do is, how do you do an FNSE is you take a sample, send it to your lab, and they measure the FNSE, and they tell you whether you have a tumor or not. So what we are trying to attempt here is, this is still a cumbersome one, we should do it before the procedure. You take a lenticule, send it, analyze the lysyl oxidase and collagen, and if your lysyl oxidase and collagen is there, after some time you can decide if your lysyl oxidase is lower, then you can actually consider doing a cross-linking later, maybe a day or two later. But if you make this process faster, then probably we can decide immediately whether we need to do a cross-linking or not. This would probably be a big game changer in the process. To summarize, we are moving out of topographers alone. Epithelial maps have a huge role, especially in today's context. What I feel is next generation of ultra high resolution OCTs will look at the Bowman's and collagen better. CLEX is going to stay. Only thing is the newer versions of CLEX procedures in terms of the energies, the shaping, and what it does. Customized lasers will also have a parallel role because every company is designing customized lasers. I think ray tracing is one area of work. Maybe tomorrow we might have something different. And most important thing in 2025 and beyond is how you understand the immunologies and how you understand the cellular status of the eye, because that determines how your outcome is going to be. And thank you.
Thanks a lot, sir. So two key takeaways that I feel from this talk were very important is for most of the people, it's so difficult to go into the trade and find the machine. You know, and I mean, I think the onus falls on few people to be able to tell us which machine is doing what good and what bad and what it doesn't do. And it's talks like these where you come to know, which, you know, and tend to make up your mind on what to get. The second very important thing that I've come to realize more and more is, you know, to look at the patient as a whole and not look at the eye. There's a lot of times I've burned my fingers, and every time I listen to your talk, I go back with the knowledge, but it'll sort of drift away in a few days, and I'll start zoning back into the eye and not the patient. But picking up and trying to avoid complications by doing immune assays, by looking at the genetic profile of patients and so on and so forth may play a very huge role in times to come, as I can see very evidently from your presentation.
See, if you look at in your own practice, all of you here have a very good premium practice. What makes them to come back again and again to your clinic? It's not your lasers anymore. It's not a complication of your cataracts anymore. It's your dry eye, it's your pain, it's your phantom symptoms, it's your nociceptive symptoms. We did evaluate our own thing. 68% of them come only because they have nociceptive driven factors. And nociceptive driven factors, whatever procedures you do, are not driven by directly by your surgical technique or a machine. So that means that there is a huge way of what we are missing in our diagnostic capacity as trying to understand it. And today, because everybody goes back into the same computers, TV, and all that stuff. So I feel more and more and all the procedures today, whether you're looking at the ray tracing, whether you're looking at InnoVice or SWIND or any of this, they assume that the healing of your epithelium and stroma is on a particular, they have a standard way of how they assume. The assumption is based on a normal healing, which is there in published literature maybe 10 or 15 years back. But what happens when you're healing is the healing in a contact lens wearer is different. The healing in a thyroid patient is different. The healing in these patients are different. So when you have a healing which is different, 10 microns of it will offset every ray tracing aspericity which you want to create. 2 microns of 6 microns of inferior superior change will offset any kind of EDOF lens you put. So ultimately, whatever you assume is an assumption hypothesis. And assumption hypothesis does not take into account of your individual biology. Your customization of IOL is based on individual biometry, but your biology is not under your control. So that is why I think we're still going to have challenges with this, and it's going to increase. The baby boomers who are going to come and get cataracts are going to be a different lifestyle compared to our parents and grandparents, where the lifestyle is completely different. So our whole dimensions will change over
And
time.
also the fact sometimes you get to, at least if nothing else, tell the patient where the problem is. You may not have a solution, but half the time they're coming into your clinic and you're just changing medicines after medicines. They want to know what the problem is, and sometimes just a confirmation that your D3 is low, your B12 is low, or you have lipid glands missing out is enough for them to understand that it's it's not something that we have done, or it's at least there is a closure to the whole
See,
problem.
Dr. Audrey is here. Today's major challenge is nociception. Nociceptive factors being increased. You yourself, when we were there, when you have challenges looking at the sunlight, you
Yes.
feel that you cannot, because it starts watering. The nociception is what makes you, all the people who write on Google review about you, which is things have gone wrong, if you really look at that, you will see 85% of them have an exaggerated nociception. Today's younger generation has nociceptive issues which is not managed by your drugs. Steroids don't change nociception. And because the nociceptive ion channels are not changed by steroids. So until unless you all as leaders in cornea thing look at nociceptive factors, the next generation of medicines, Alcon is coming out with a new dry eye drug, it increases the TRPM8. That is, increase the nociceptive factors. So I feel we are changing the way we are going to manage these diseases.
Thanks a lot, sir. Anyone has any comment to add? Okay, so I thank all the speakers and the people attending the session. Instruction course. If we can have all the speakers for a photograph.